Hello, everyone. A very good afternoon to you all. Myself, Dr. Sumedha Gupta, and on behalf of Voice of Healthcare, I would like to welcome all the viewers who have joined us. So, today, we are here to present the third episode of Detect to Protect, a series of awareness session in the fight against breast cancer, organized by Voice of Healthcare and supported by Zydus Life. In today's session, we'll explore about the vital insights on breast cancer from recognizing the signs and symptoms to the importance of early detection, prognostic testing, policy advocacy, and the latest treatment options. So let's come together to empower ourselves with knowledge that protects women health. Before starting the discussion, I would like to share some facts about the breast cancer prevalence in India. Breast cancer in India possesses a significant public health challenge, accounting for about 14% of the global burden. The incidence is rising at 1.5 to 2% annually, with approximately 60% of cases diagnosed at advanced stages, severely impacting the treatment outcomes. The average age of diagnosis is around 45, younger than the global average of 61, and survival rates varies widely, 70 to 80% in the urban areas in comparison to the 40 to 50% in rural areas. Awareness of symptoms is really low, with only 20 to 30% of women informed about the disease, and less than 10% participate in the regular screening. Cultural barriers and stigma further impede timely medical help, especially for the women with a family history of breast cancer, who are at the 2-3 times higher risk. These factors highlight the urgent need for improved awareness, education, and healthcare access to address the rising burden of breast cancer in India. And in the light of these stats and facts, to begin with the discussion, first I would like you all to please join me in welcoming our experts who are going to provide us with insightful information on understanding about the breast cancer awareness. So I would like to welcome Dr. D.G. Vijay, Senior Consultant, Breast Cancer and Thoracic Cancer Services at CG Cancer Center, Ahmedabad. Welcome to the discussion, Doctor. Moving ahead, I would like to welcome Dr. Rajeev Kumar, Senior Consultant, Chief of Breast Services, Rajiv Gandhi Cancer Institute, Rohini, Niti, Bagh, New Delhi. Good afternoon, Doctor. Welcome to the discussion.
Thank you.
Moving ahead, I would like to welcome Dr. Atul Batra, Additional Professor, Medical Oncology, AIIMS, New Delhi. Good afternoon, Doctor. Welcome to the discussion.
Good afternoon. Thank you.
Moving ahead, I would like to welcome Dr. K. Madan Gopal, Advisor, Public Health Administration, NHSRC, Ministry of Health and Family Welfare, Government of India. Welcome to the discussion, Doctor. So let's delve into the discussion. To begin the discussion with the understanding of early signs and symptoms of breast cancer, I would like to have the views with Dr. Rajeev Kumar. If a woman notices a change in her breast, like lumps or
Thank you
unusual
very much
texture, so I would like to ask Dr. Rajeev, if a woman notices a change in her breast, like lumps or unusual texture, how can she tell if she changes are serious enough to see a doctor? Dr. Rajeev, can you hear us? I think there is some connection issue with Dr. Rajeev. Moving to Dr. Vijay, I would like to have your views on like what are some of the most important early signs and symptoms of breast cancer that women should pay attention to, and why are these signs so critical? Dr. Vijay, can you please unmute your mic?
Yeah.
Yeah.
I think, okay. Is it unmuted now?
Yes, you're audible to us.
So, some of the early signs and symptoms of breast cancer are basically it's a breast lump. There could be nipple retraction. There could be nipple discharge. Most of the time, the nipple discharge is either bloody or it could be thin, serous, watery. It is usually in an elderly lady. Having said that, we also see breast cancer in about younger women who are less than 40 years of age. There are a lot of associated skin changes. For the example, edema, ulceration, or pitting of the skin. She could even have some axillary swelling, swelling in the armpits. But at this point of time, we want to make it very clear that pain, classic, is not a very standard sign symptom of breast cancer. So we would advise women not to, a painless lump is probably the most common presentation of breast cancer.
Thank you, Dr. Vijay, for your insights on early sign and symptoms. Moving ahead with the discussion to Dr. Rajiv, I would like to have your views on if a woman notices a change in her breast, like lumps or unusual texture, how can she tell if these changes are serious enough to see the doctor? Dr. Rajiv, can you hear me? I think there is some network issue with Dr. Rajiv. Moving ahead to Dr. Atul, I would like to have your views on, like, are there any specific age group or certain women who should be especially careful and watch these signs for breast cancer?
See, the risk of breast cancer keeps increasing with age, and we see most of our breast cancers in fourth, fifth decade of life, and it increases with age. But there's no age where we can say that a breast lump may not be a breast cancer. I mean, the chances of breast cancer in a younger woman with a lump would be lower because there are other benign diseases that happen due to the hormonal changes that happen with the menstrual cycle. But still, we have seen patients with breast cancer as young as 18 years, 20 years of age. Having said that, I don't want to kind of scare all the young girls that any breast lump would be a breast cancer. It's not like that. The chances would be low in younger patients, quite low. But still, if you feel that there are something that is kind of bothering, a painless lump is there, which is kind of in a same position, staying there, they may consult a doctor and then see if that needs further evaluation or not. A diagnosis would typically be made with first a clinical examination and then some kind of imaging would be done in younger patients. If needed, an ultrasound can be done, and if there are some suspicions still remaining, and then a biopsy is typically done. But if it is clear that on clinical examination it does not look like, then there may not be any need of doing any further investigation. Or if there is a need of ultrasound and ultrasound is quite reassuring, then it is not needed. Sometimes it is borderline and you need to kind of keep under follow up and get yourself evaluated. Chances increases when the age increases. So a breast lump in a 60-year-old lady would be much more kind of risky to have a breast cancer rather than a younger age group. So, but it needs to be evaluated. The commonest symptom is a painless lump that is there, but other symptoms could be there, including any nipple discharge, changing in skin texture. As our previous speaker was mentioning, all those changes need to be reported and get evaluated by a physician.
On the following up to this insights of yours, Dr. Atul, I would like to ask if a woman notices a certain changes in her breast. I mean, how can she tell like these changes are this serious and she need to see a doctor?
I mean, it is a tough one because the most common presentation I was earlier mentioning was a painless lump. It does not, a small lump will not cause any visible changes. It is usually an incidental finding while you are doing something, you kind of notice a lump, or you are doing a self breast examination. There are several breast examination videos that are available to guide them properly when to do, how to do, which part of the menstrual cycle, how to go about it. Those are the most common changes. But if you see changes that there's some nipple discharge, or there is skin pitting that is new onset, there is asymmetry in the breast, one of the breast is becoming larger, skin is thickened, there is pitting, there is any ulceration, painless lump, all those things need to be kind of you need to get them evaluated. So a change is more important rather than anything absolute. So if a new thing has come up over last several weeks or months, then that needs to be reported for sure.
Thank you, Dr. Atul, for your insights onto that. Moving ahead with the discussion to Dr. Gopal, I would like to have your views on what important programs has the government put in place to help women learn about the breast cancer and get screened.
Uh, Thank you, Sumedha. One of the important things, one is awareness about the breast cancer, and the second thing is awareness about what government is doing and what government programs are there. But nevertheless, we need to emphasize that the screening is very important. If you look at the screening statistics in India, the because screening is becomes of paramount importance because we have been focusing on early diagnosis so that the survival can increase. If you look at the screening statistics, in India, only 10% of the women they undergo screening, and if you look at the US and other countries, there the screening ranges from 70 to 90%, and this essentially will impact your survival chances. If you because the cancer, the 5 year survival rates are usually measured. In India, the cancer 5 year survival rates are in the range of 40 to 60%, whereas in US it is ranges from 70 to 90%. So that kind of thing is there. But recognizing the importance of that, we do have a national program for non-communicable disease, and we do have mechanism. This screening program, and the government is having an emphasis on screening of breast cancer. Along with the breast cancer, the other cancers also they have been added to the list. We do have a certain mechanism. If you look at the number of institutions which the public sector is having, we do have around 2 lakh 10,000 health institutions to which all the services are provided. We have talked about the footfalls. The footfalls in the public sector and the private sector more or less are similar. It ranges from 45% to 55% depending on the area. In some of the areas, it's only the public sector which turns to the people, and we should always remember the presence of public sector right up to the village level. That means, if you talk about the structure, three-tier structure, uh, it starts from the sub-health center, the primary health center, the community health center, and the district hospital. Now, with the government plans of having each in having a medical college in each of the district, we will see that the touch level services is also there. The peripheral most unit, that is the sub-health center, which is listed as the Ayushman Arogya Mandir, they provide the preventive, promotive, as well as screening services. And these centers are manned by a nursing staff. She is BSc in nursing. She is a qualified person who is there, and assisted by the outreach worker, the ANMs and the ASHAs. ASHAs are there in all the villages. They cater to the population list. With the help of them through a symptomatic checklist, we are trying to bring and make the people aware about how to make a self-examination of the breast. And after something is found, a painless lump or if the size of the breast is increasing, with a simple symptomatology, what is happening, we are trying to see that how they are connected to the higher centers. We do have another program which is e-Sanjeevani. After the COVID, the major taker of this telemedicine has been the public sector. We have rolled out the e-Sanjeevani program in which the doctor to doctor consultation happens. That means when the screening is happening at the peripheral most level, because at that level there is no private hospital. At the primary health center also there is no private hospital. At the community health center also at the block level there are very few only nursing homes over there. They are not run by MBBS doctors. The presence of a private sector is more or less restricted to district headquarters or the state headquarters, or at the most at some places in the scattered way that would be. So these are the people who is doing the screening based on the actual symptomatology. In case of further referral is required, they would be connecting to the health centers through telemedicine, and after that they are referred to the community health center, the district hospital, or the medical college for further evaluation if the need may be. So apart from that, at the district level, we do have tests for cytology, and even some of the blocks also on a base of this the hub and spoke model. The samples can be transported to the district level of the medical colleges for examination. That means effectively we have been able to cater to around more than 65% population like this. So it would be very, because awareness about what the government is doing is one of the major bottlenecks. We only think that it's only happening in the cities, but no, lot of screening is happening. But still, even after raising lot of awareness, you see, we are having a 1 million women volunteers, the ASHA workers. To add to that, we are having around 40,000 ANMs who are women. But still, the screening of women patients is less than 10%. It's around 10%. It means lot of awareness is required. Even the self-examination of breast we have been propagating, that also needs to be percolated. And besides that, apart from this, the other cancers also needs to be screened. It's not that only one cancer is to be screened. We do have a checklist at, right up to the, so that screening happens. Once the screening happens, they are brought to the centers for treatment, and that mechanism is there. We do have free drugs and diagnostics, and whatever treatment can be provided free of cost, which is provided free of cost. Further, for the vulnerable section, that means the people who are poor, who can't afford medicine. So PMJ program is there. In PMJ, most of the cancers they are covered. The packages are there. They are indicative. Everybody can contest that the rates are low. But let's start using the rates. If based on the experience, we can always take a call whether the rates are adequate or not. But the experience is coming and the scheme is also evolving. As the scheme evolves, we'll see that how right from preventive from auto right up to the curative level. So that kind of mechanism is there, and the government is already conscious about and is doing uh, is catering to the needs of all the people. I stop here. Any other question? I would be glad to take that.
Thank you, Dr. Gopal, for providing us with these valuable insights on different programs and initiatives organized by government. Moving ahead with the discussion to Dr. Vijay, I would like to ask, I mean, what are the self-screening methods and how prevalent or how urgently a woman should self-screen herself, and what are the factors that define this, and what age group should a woman start doing herself self-screened?
And I think as the president of the ABSI, Association of Breast Surgeons of India, I think the statistics of breast cancer also needs to be mentioned in the beginning. That in India we see about 250,000 new cases of breast cancer every year. So as Dr. Gopal was mentioning, uh, nearly 50%. I also agree with Dr. Atul that 9 out of 10 lumps in the younger women are likely to be benign. So
Yeah.
we just need to reassure the young women, but they can't tell it on their own. They need to seek medical attention, possibly a family physician or their gynecologist, and get investigated appropriately if required. Coming to your question of breast self-examination, women can generally be divided into two categories: the low risk, who are not at very high predilection for developing breast cancer. So the average population, as we would call them, they
Yeah.
can start doing breast self-examination. It only creates a certain sense of awareness within their brain. So they can do it after about 7 to 10 days after their last cycle of menstruation. And just a minute. Can you hear me? Yeah. So they can do
Yes.
it after
Yes.
7 to 10 days after their last cycle after menstruation. And for women who have undergone hysterectomy or are post-menopausal, they can select a certain day, the 5th, or the 1st, or the 15th, or the 30th, the last day of every month, and then with their left hand they can examine the right breast, and with the right hand they can examine the left breast, keeping the hand flat, basically looking for changes and being aware. So like Dr. Atul mentioned, it's also important to be aware of certain changes taking place in your own breast, whether it is becoming harder some places, whether the nipple is getting retracted, whether they can feel a lump, whether they notice any skin changes. So these are for women who are at high risk because they have a family history of breast cancer or are genetically predisposed. Obviously, the screening is likely to be more intensive. Not only breast examination, we would also want to do imaging in the form of mammography and MRI at earlier ages.
Thank you, Dr. Vijay, for your insights onto that. On the following up to this, I mean, how does early detection through these screenings impact the likelihood of successful treatment outcomes? What are your views onto that, Dr. Vijay?
Like Dr. Gopal mentioned, in the US and Western countries, nearly 80-90% of their population is diagnosed in stage 0, preclinical stage, and stage 1. And therefore, the rates of cure are in the region of about 95 to 100%. So it's very important to detect breast cancer in its preclinical stage, or at least in the stage 1. Many women with early breast cancer, we can avoid mastectomy. Women have a great fear of losing their breast. So if they come to us in early stages, in nearly 60-70% of cases, we will be able to conserve the breast. We Some women, we might, because they are small tumors, node negative, we might be able to avoid chemotherapy. In elderly women with small tumors, we may be able to avoid radiotherapy. And at the end of the day, women with early breast cancers live longer, they have a better quality of life, and their chances psychological rehabilitation is much better when you detect the breast cancer in an earlier stage.
Thank you, Dr. Vijay, for your insights onto that. And I think this is going to be really valuable and helpful for the people who are seeking for this. Moving ahead with the discussion to Dr. Atul Batra, I would like to know your views. How do genetic factors like BRCA1 and BRCA2 mutation increases a women risk of breast cancer? And what new technologies, or I would say the advancements, have been made in breast cancer screening that can help to catch up with the disease sooner?
So there are two questions to it. One, the first one is on genetics, and the second one
Genetic.
is on screening. So let us take the first one, which is genetic. So if we look at all the breast cancer cases, around 15 to 20% of them will have some genetic mutation. In fact, a study that was done from AIIMS itself that showed around 18% of patients had a mutation that was present in one of the genes. So there are several genes that can increase the risk of breast cancer, but the most common, as you said, are BRCA1 and 2. And these two genes by themselves are responsible for 12% out of those 18%. And rest all other genes were responsible for 6%. Now coming to what are these and how do these affect the risk of breast cancer? Genes are basically made up of DNA, and these are basically the code of our life, right? Whatever is written with those four letters is being coded. So these are mainly the DNA repair pathway genes, BRCA1 and 2. So whatever there is a constant insult going on in the DNA, which is being repaired by the body. But if this repair mechanism is not right in your body, so that cannot fix up the damage, and this damage leads to cancer. What is the risk of cancer in patients who have BRCA1 or 2 mutations? So during their full lifetime, there is around 70 to 80% risk of developing a breast cancer in such women who have this mutation. There's some variability seen with different kind of mutations, but broadly it lies in 60 to 80% of the range. We all have heard about Angelina Jolie, who got preventive mastectomy done because she was a carrier of one of these mutations, and that is how it has gained worldwide. I mean, people know about this. Awareness of this genes has been possible mainly because of that. So there are specific indications to test, and these indications are increasing day by day. But broadly, if the patient is young, has a triple negative breast cancer, that is a subtype of breast cancer we see in younger females where all those genes are negative, and those where family history is strong, where the patient has both side breast cancer or breast and ovarian cancer. If it is a male breast cancer, which is often so less talked about, but it's still an entity, many male men do not even know that there is something called as male breast cancer. So these are broadly the indications of doing a genetic testing, which has a lot of implications. I mean, it should not just be advised on a piece of paper. You need to discuss the pre-test counseling, then you undergo the test, and then there is a post-test counseling, because the implications are not just on an individual, that is on family testing as well, on an individual also, what is the future risk. So all these need to be discussed in great detail, and so this is about genetics very, very briefly. There's a lot more to it. There are a lot more genes. There are a lot of other things that affect. And the second question was screening. So one
Yeah.
is a population screening and one is the high risk screening. The standard thing that we use for population screening in Western world is a bilateral mammogram, which is started at the age of 40 to 45 years and it ends at around 70 to 75 years. Some countries recommend doing it every year, like the US, and some countries do it at 2 to 3 years, mainly in the Europe or UK, Canada. It is mainly every 2 to 3 years. And the simplest way of doing it is breast self examination, but in countries where most of it is actually very early breast cancer, it is not shown to be effective. But in countries like India, where patients come up with a large lump, even a breast self examination can at least bring them at an earlier stage, and it has been shown that it is effective. What is the new advancement going on? There is a lot of stuff of artificial intelligence which is now entering into reading up the mammograms. One, so it can even pick up, because it is kind of based on a pattern. So artificial intelligence is big time into reading those mammograms. There's a lot of concern with ultrasound screening because it is subjective, dependent on operator who is doing it. So ultrasound is done at specific indications when needed. But again, robotic ultrasounds, AI are new advancements that are still in kind of research, but are being well studied in this area. Coming on to the breast MRIs. So breast MRIs are done when the risk of breast cancer is higher than the population, which is typically when the patient has, say, a BRCA mutation and she does not want to undergo a mastectomy currently. So we follow them doing a surveillance program, which consists of annual MRIs of both the breast. And this is supplemented using an alternate mammograms as well, and ultrasounds with mammograms using that. But MRI is used typically when the risk of having breast cancer is high. Apart from BRCA mutation, the patient has had radiation to chest wall, and otherwise, if the risk is higher, these are the typical modalities that we use to detect breast cancer. And then there are some other imaging that is used for staging, like PET scans or CT scans, bone scans. Those are done to detect the stage of breast cancer, whether it is gone outside the breast or not.
Thank you, Dr. Atul, for these insights. In continuation to that screening part, I would also like to know your views onto that. Are there any specific Indian guidelines for the screening of breast cancer in comparison to the Western guidelines, since you mentioned about different countries and geographical region differences?
So if we look at the first of all, we need to know what is the risk in an average Indian woman as compared to an average American woman. The breast cancer incidence that we talk about in India is around 3 to 4 times less than in Americas, where it is more than over 100 per. We measure it in per lakh population. Actually, it is a standardized population way to do it, but broadly it is per 100,000 or per lakh women. It is around more than 100 in most of the developed countries, somewhere 110, 120. In India, it is a very, very heterogeneous kind of incidence. If you look at registries like Delhi, Mumbai, Hyderabad, Chennai, here the risk of breast cancer is actually increasing quite rapidly with each and every analysis that is being done to look at the incidence, and reaching as high as 60 per 100,000. But if you look at the registries that come from rural areas like Barshi or other, there the incidence of breast cancer is actually quite low, maybe between 10 to 20 per 100,000. Right? So our incidence as such is less than the developed world. One, because we also do not have a screening program in place which is working. Second, there is still the incidence is low, because as we see that as our lifestyle is moving from rural to urban, or from an eastern to western kind of lifestyle, we are seeing that increase in breast cancer. And eventually we are going to see a big epidemic that is coming over next 10 to 20 years. If the rates reach that level of incidence like in the west, then our total number of cases, which are currently around 2 lakh 20 30,000, are going to increase to maybe 6 7 lakhs, 600,000 to 700,000 over coming years, which is quite astonishing. I mean, it will take time to reach those numbers, but our projections are probably around 2 lakh 75 or 2 lakh 80,000 reaching in 2030 itself. So we do not have enough mammogram machines actually to do a nationwide mammography screening program. There was a study which was done from Tata Mumbai that also showed that breast self-examination, clinical breast examination, all supplemented by that, is also effective in detecting the breast cancers early. And if you also look at the distribution of breast cancer in India, out of 100 patients with breast cancer, only around 20 to 25 present at an early stage. Around 55 to 60% would be at a locally advanced stage, and around 10% or so will be in the metastatic stage. If you compare this with Western world, around 70-80% of them would present at an early stage. So our priority should be to bring those locally advanced into early. And for that, we do not even need mammograms, because these patients present with a very large mass. So if you are able to do a self-breast examination or a clinical breast examination and bring them to early, that itself will reduce a lot of mortality amongst breast cancer patients. Out of these 2 lakh or odd breast cancer patients, approximately half of these patients are dying in India. If you look at the number of deaths in India due to breast cancer, it is way higher than the number of deaths in America. Although we have similar number of cases, absolute number of cases in US compared to India. Mind you, US has approximately one third of population than India. So a lot needs to be done to bring these locally advanced breast cancer patients into early stage, and that can be achievable first with self-breast slash clinical examinations, and then once we are able to bring them early, then we need to bring them into very early, and that can be achieved later with mammographic screening as well.
Thank you, Dr.
That's
Atul, for these insights onto that. Uh, Moving ahead with the discussion to Dr. Gopal, I would like to have your views onto that how policy advocacy helps makes it easier for a woman to access breast cancer care, especially those living in the rural areas, and how can public health agencies and NGOs can work better to address the issue of breast cancer in such communities.
Dr. Sumedha, one of the problems which we face is the numbers. We are talking about 1.4 billion population, of which around 40% would be falling in this age bracket. Okay, we see
Yeah.
that number is there. That's why a structure which I've explained earlier that exists. But one of the challenges we are experimenting. That means the self-examination of the breast, how to get the people engaged into a self-examination. First is identification. That means who are the people. We have been training, and training. That's the only answer which we are having. We're training the health professionals, health providers in at least motivating the women to do a self-examination, as Dr. Vijay has mentioned how to do that. We have been motivated to do that. And as a result of all these efforts, if you look at the way how we have progressed, we have moved from primary healthcare to comprehensive primary healthcare. One of the key components of the comprehensive primary care is your screening for cancers and the palliative care. Both the things are there. For a population which is assigned to a Ayushman Arogya Mandir, at around 5,000 population. So they are being tasked to screen whole of the population for all the disease, including cancers. We are not focusing only on breast cancer, but it is cancer of cervix, cancer of lung, cancer of throat. All the four cancers are being searched when we are doing the screening. After they are screened, one of the biggest challenges is still how to motivate the rural people to do a self-examination. So there is
Yeah.
one other innovative method, because in Western countries, even the male partners, they are also being capacitated to do the examination. there would be many stories and instances where the male partner has identified a lump and he has brought the patient to the doctor and the cancer was detected on an early basis. Here, that kind of thing is not there. The moment you approach the partners and others, that means we have to see that apart from the women, their immediate caregivers and the partner, they needs to be sensitized that in case of any lump, in case of any other early signs, that needs to be recognized and yeah, even after recognition, the person, the caregiver, the immediate caregiver, the million of your healthcare workers and the 20,000 ANMs others and the CHOs which are there, we see that how even if a woman notices a symptom, they should examine that and immediately consult the doctor at the higher up. That kind of thing is work in progress. It's not that nothing is happening. Things are happening, they are falling in place, but still lot of impetus is to be given. It needs to be further strengthened and see that the efforts which you are making, they move very fast, they accelerate, and that acceleration only can happen when the self-examination comes to prominence. That means lot of awareness activities are to be done for doing the self-examination things. That's one thing. After doing the self-examination, now we have to capacitate the system. The system capacitation is also happening. That there are the training modules are there for the a million of ASHA workers. There's a training module for the community health officers. There's a training for the ANMs also. Side by side, we are capacitating the healthcare providers. The learning modules are there, how to examine the best and what kind of treatment is to be given. All the things are there, but only thing is we have to accelerate the implementation. The work is in progress. We see that how this works in progress is further accelerated so that the screening, which is currently at 10%, the 10% of the women who are regularly screened, it becomes at least on an incremental basis every year, at least 10%, 20% more are added. The target-based approach are also being factored. Some of the states they are targeting, they are tying up with the medical colleges in that. The example is in Andhra Pradesh. They are tying up with the AIIMS as well as the Cancer Institute there. They have screened whole of the population there, more than 90% of the population they have been able to screen. After screening, they have been able to identify who are the people who will be requiring a second level of investigations and other things. So that kind of approach is now setting into the system so that more and more number are detected as early as possible so that the longevity as well as the productive life of these patients is increased. Otherwise, what happens, we detect them either on the stage 2 or stage 4. So, and till the time they came to us, it's only palliative therapy and only and as a result, the survival is also less. And if you see the investment from our point of view is the prevention only. Even if I create 100,000 beds for this cancer treatment, that won't suffice. If the if that won't suffice, it would be taken up immediately in 3 4 months. It would be all occupied. So that kind of thing. The only way is to prevent or prevention. One of the important strategies which everybody propagates for a population size like this is education, making the people aware, and then self-examination of the breast, capacitating of the providers in at least arriving at some conclusion, and after coming to conclusion, proper investigation and treatment. That kind of modality, that kind of ecosystem has been created for the cancer services. And the tertiary level thing, the private sector is there, the medical colleges are there, they are already catering to that. Thank you.
Well, that's really enlightening to know about the different policies and how it's working in issue to the public awareness and the effectiveness. Moving ahead with the modern breast cancer treatments, I would like to have the views of Dr. Vijay. Since our theme is detect to protect, can you please elaborate on how early detection of breast cancer can influence the treatment methods across the different stages of the disease, and what advantages does identifying the cancer early provide in terms of treatment option and overall patient outcome?
I think I spoke about this in the context of the previous question, but there is no harm in repeating myself when I say that this program of detect to protect, if we are able to detect breast cancer in stages 0 preclinical and stage 1 early breast cancer, our cure rates will shoot through the roof to about 90, 95 to even 100%. I also said that in patients, young women with breast cancer, if we detect them early, we can avoid mastectomy. We may be able to avoid chemotherapy in some women. We may be able to avoid radiotherapy in elderly women with early breast cancer. And these women certainly live longer, have an excellent quality of life, and have excellent psychological rehabilitation even after suffering from breast cancer. The uh, October is Breast Cancer Awareness Month, as you are well aware, and as the president of ABSI, Association of Breast Surgeons of India, we work closely with the government. In fact, our slogan for this year is awareness campaign for various events all across the country, uh, working with the government offices and factories, and create awareness among the women and the men who work there so that they come to the medical center for early detection and treatment. EBSI also has got modules. So we work with Dr. Gopal was talking about a medical college in every district. So we talk to the MBBS students to sensitize them about breast cancer. We talk to students who are doing their post graduation MS and teach them the correct techniques of doing breast surgery. And we go to those who are doing their super specialization in surgical oncology and talk to them about advances taking place in breast cancer. So it is what breast cancer is only a marker. So if the incidence goes down, or if we are able to detect breast cancer early, it's reflective of a healthy lifestyle. It's just one aspect of the many diseases that, for example, healthy, unhealthy lifestyle, obesity, diet, the whole thing is just one uh, bag. And we talk about breast cancer in October because if we are able to bring down the incidence or detect it early, then in the next couple of decades, as Dr. Gopal and Atul mentioned, it is reflective in the change in the lifestyle of the Indian population, which is resulting in better health for our own people.
Thank you, Dr. Vijay, for these insights. In continuation of that, I would like to have your views on what are the most common side effects of breast cancer treatment and how can the patient manage these to maintain a better quality of life simultaneously.
So, the complications or the sequelae or the subsequent side effects of treatment could be in the form when we do breast surgery. Nearly in the higher centers, it is less, but I would say on an average, 50% of women are likely to lose their breast by the surgery, which is called mastectomy. Currently, we are in a position to offer breast reconstruction either with implant or their own body tissue. I would say to less than 5 to 10% of all women undergoing mastectomy. The other sequelae is patients, because they come with lymph nodes in their armpits, they undergo axillary lymph node dissection by which they develop lymphedema of the hand, which is a swelling, almost debilitating, long term, severe side effect of uh, breast cancer surgery. Many of the side effects of chemotherapy are well known, and the most obvious one of them is alopecia or hair loss. At our center, we have a scalp cooling device which cools the scalp and mitigates the side effects of chemotherapy, but uh, yet it will occur to some extent: nausea, vomiting, diarrhea, constipation, decrease in your counts, white blood cells, hemoglobin. All these, fever, are some of the different chemotherapy drugs have different side effects. Again, many women require radiation, so there is blackening of the skin, there is skin fibrosis. Of the
Hmm.
many newer drugs that are available, for example, anti-HER2 drugs or immunotherapy, they give very good results, but they come with their own set of problems where they may affect the functioning of the heart, the pumping of the heart, the ejection fraction might go down. There may be immune reactions affecting the thyroid, the liver. So we need, so it's a joint decision taken by the patient and the treating clinician, and all these side effects are freely discussed with the patient before initiating the treatment.
Thank you, Dr. Vijay, for your valuable insights onto that. Moving ahead with the discussion to Dr. Batra, I would like to have your views on the role of the prognostic testing in breast cancer and why it is important for the patient and how the result of these tests can influence the treatment decision and overall management of the disease.
So by prognostic tests, there are several prognostic tests, that are available. So one, I think that you are mentioning to are the prognostic genomic tests, right? Like the Oncotype DX or MammaPrint and the ProSigna and several other. So what happens is in patients who are hormone receptor positive, subtype of breast cancer, which is the actually the most common type of breast cancer, if these patients come at an early stage, many of them do not benefit from chemotherapy, right? Why do we give chemotherapy? I'm raising all these questions just to make sure that people who are listening do understand what is the role of chemotherapy in breast cancer. Basically, even at an early stage, what happens is when the breast cancer is growing, there are some cells that are moving out of the breast, going to other parts of the body, either circulating in the blood, via circulating, going into certain organs, even at a very early stage. They form some niches there, and that is not detectable when we do a CT scan or PET scan unless it reaches a some size, say 0.5 centimeter, which requires millions or billions of cells. Now, if we do the surgery, we are removing the cancer cells from there, and if we don't do anything, some proportion of these patients will have a recurrence years after that, maybe 6 months, maybe 1 year, 5 years, 10 years after that. These patients can have a recurrence in bone, lung, liver, brain, anywhere in the body. And at that time, these patients are treatable, but it cannot be typically cured because it is a stage 4 cancer now. So the purpose of giving any treatment that we give apart from surgery is to prevent these recurrences. And to prevent these recurrences, these cells that have migrated from there, these cancer cells need to be killed. These can be killed either with chemotherapy, hormone therapy, targeted therapy, immunotherapy, anything that goes throughout the body. So some patients who are hormone receptor positive have an early stage, may not benefit from chemotherapy, and their cancer cells may be taken care of, those that have gone out, with just hormone therapy. So these kind of patients, their tumor is dependent more on the body's estrogen, which is female hormone, and there are several medications that are given either to block the production of estrogen or to prevent the action of estrogen on estrogen receptor. So this subset of population will benefit from doing such a test where we can actually be sure. What is the problem with doing in such a test? That these so-called gold standard tests that have been devised roughly range from the cost of around 2 to 3 lakhs per patient if we want to do. And this has to be done in a very chosen kind of patient where we think that the benefit of chemotherapy would be kind of falling in gray zone. It is not too much, but it can be exactly classified using one of these tests. The problems comes with affordability because of the cost of the test. That is for Oncotype DX, it goes to up to I think 3.2 lakhs. So these are extremely expensive. Instead of that, we use kind of surrogate markers that are available readily available in the pathology report with the surgery, like what is the grade of the tumor, what is the P67. There are some markers that are reported routinely with that. So in patients where it is not possible to do those tests, these can be done with reasonable confidence in some patients and not possibly in other patients. So these are important tests, but still out of reach of most of our patients working at AIIMS. Most of our patients would not be able to take those tests. So, and it is okay not to do in many of those, because in many patients you can take that decision with a reasonable confidence in using the other surrogate marker. Right? I hope that was your question regarding these prognosticators.
Yes, thank you, Dr. Batra. I would like to mention that you have explained this in a manner that one layman can also understand it and can be aware about this prognostic testing. Moving ahead with the discussion to Dr. Gopal, I would like to ask how can patients and advocates get involved in influencing government policy to ensure that better resources are available for breast cancer treatment?
That's a very catch-22 question because resources are currently available, they are not utilized. That's a question which we can always pose. But it's very important that the patient and the patient groups they become aware what programs government is doing. Even the doctors they need to be aware that what government is doing. They need to be aware about that. The screening program is there. How to popularize that screening program? The moment it becomes a problem, that means if we are able to screen population and the requirements are there, always the further course of action can always be planned. It's not that resources are not available. Resources are always available. If you look at the things how it progresses, self screening is there. Some of the states they have started the mammography is also there. The projects on AI mammography and AI that kind of projects are also being planned wherever the incidence is high. The government is doing that. So beside that, after the investigations, other things happen. They are being provided free of cost treatment in the government institution wherever it's possible. And PMJ also is there, so in which subsidized treatments are being provided. Packages are there for cancers. Packages are for if you talk about the breast surgeries that is there, even for radical mastectomy to a lump removal that is there. For chemotherapy, that package is also there. For radiation, that package is also there. The only thing is how many people are aware of utilizing these resources. It's very easy to say that resources, we should ask for more resources. But whatever is existing, how much we are able to utilize that resources, that's the question we need to ask. For that, lot of awareness is required in the patients, patient support groups, the non-governmental organization working with the patients, and the providers who are in direct touch with the patients. We see that how this whole ecosystem of the patient, they are being empowered with information, they are empowered with capacity to do self-examination, they are empowered to seek support from the public institutions about the treatment of the modalities. So that kind of thing is required. The resources are there. Your question was about the resources. Resources are there. If the patient
Yeah.
starts utilizing the services, obviously, if more services are required, then that can be planned subsequently. Currently, as you have seen the screening said less than 10%, 10% screening. That means we are envisaging that more than 90% of the population will be screened, the patient and the cases identified, and the cases are being provided treatment. But it's very difficult to reach that figure unless all all whole approach is there. That means the patient, the providers, and the government, all the three come together and make a wholehearted effort in seeing that whatever thing is available, it is used to the optimum, and whatever resources are there, they can be put to optimal use. We at least exhaust the resources, then we can ask and ask for more resources.
Thank you, Dr. Gopal, for your insights onto that. And I think people should be more aware about such government policies and they should ensure themselves that they get the better resource and available for all the breast cancer treatment. So, in conclusion, our objective for today's discussion was to explore and emphasize the importance of breast cancer by integrating insights on recognizing the signs, symptoms, the significance of early detection, policies, and different treatment options. And I'm confident that our experts have addressed this crucial topic comprehensively and effectively in the manner that laymen can also understand. I would like to extend my gratitude to all the panelists for their insightful contribution and for sharing your expertise with us today. Your participation has been really valuable and we deeply appreciate the time and knowledge that you have shared. Thank you for joining us today and for contributing this important conversation.
Thank you.
Thank you.